Hello, good morning. I'm Dr. Raja, one of the consultant forensic psychiatrists in Forensic Community Mental Health Team, Lanarkshire. I'm here today along with two of my colleagues, Maxine McDougall and Marlene Savage, FCPNs. And together we will be presenting a quality improvement project on physical health assessments of our community forensic patients in the Caird House, Beckford Lodge, in NHS Lanarkshire. One of our admin colleagues, Angela, is also helping us in the background. In terms of the project and the study that we had undertaken, it is known as Physical Health and Wellbeing project on our patients, and we'll start with the slides. The layout of the presentation is that I will present the first half of the presentation, which will be followed up by Marlene, who will be going through the physical health well-being monitoring pack, and followed by the pilot study, which will be presented by Maxine McDougall. And in the end, I will conclude the presentation. Could we please have the PowerPoint presentation, please? Thank you. So this project that we undertook, it was to do with establishing physical health and well-being monitoring clinics within Forensic Community Mental Health Services. Next slide, please. Why we established these monitoring clinics is because of the patients that we have, the kind of problems in terms of physical health that they have. We know that patients with severe enduring mental illnesses, they have lower life expectancy and poorer physical health outcomes than the general population. That means that they have excess mortality rates, which is 3.6 times higher than the general population. Why this happens? This is mostly because patients are on prescribed psychotropic medications, which have their own side effects. Patients also have comorbidities. They have different lifestyle choices that they make, and altogether it can increase the risk of physical problems, physical diseases, and physical health complications. We also know that when patients are on these medications, suboptimal monitoring is undertaken in various mental health services in the community that in itself can lead to problems. Other reasons which contribute to higher mortality rates in our patients is because of the clinical risk factors. There are socioeconomic factors such as deprivation, not having enough education, not understanding how to make the healthy lifestyle choices, and other health system factors. All these combine together, and we know that patients can become obese. They can develop metabolic side effects when they are on these medications. In addition, they can develop high blood pressure, diabetes, hypertension, and lower levels of physical activities. And that in turn leads to the development of chronic obstructive airway diseases, cerebrovascular accidents, which means patients can have strokes, and that in itself can eventually lead to the development of various cancers. We also note that there is a lack of integration between services, in regards to the care that is being provided to these patients. So we had looked at the inpatient and the forensic community mental health services. Over the years, we have noticed that their physical health monitoring had always been an issue, actually, in our side of the service. We realized that we needed to have better communication, have better IT support, and there had to be a better and a clearer understanding of all the responsibilities and the accountability for physical health care between various agencies. In addition, we were very much aware that there's a stigma attached to the physical health complications in association with mental illnesses, and so there was a need to tackle that as well, and how to deliver such service while keeping these points in consideration. Next slide, please. An audit in July 2020 was undertaken in Forensic Mental Health Services. Our service comprises of inpatient low secure forensic unit. There's an open forensic rehab ward, GIA ward, and there is forensic community mental health team. The audit constituted those patients who were on psychotropic medications for more than a year. And the selected sample included 45 patients, and their physical health parameters were looked at. So, for example, which people were smoking, their weight, blood pressure, blood investigations were looked at if they were recorded or not. And these were blood glucose, lipids, full blood count, and biochemistry and ECG. The results were compared actually between these three aspect of the services within the forensic mental health. And we found that there were clear deficiencies in the forensic community mental health side of things. For example, patients who were in the community mental health service, their weight and BMI were recorded only in 30% of the cases. In the same manner, the blood investigations, for example, lipids and hemoglobin A1C was recorded in 50%. ECG was not done properly. Only 18% patient had ECGs undertaken. In the same manner, liver function tests were only undertaken in 60% of the patients. There were various reasons which contributed towards this, and it was felt that there was non-compliance with the investigation, so the patients were not very keen. There were patients were refusing to get the blood investigations done. Also, there was unsatisfactory liaison between the clinical team and the GPs, and when the patients were asked to go to the GPs, there would be a considerable delay in their presentation. It was also very difficult for patients with chronic enduring mental health problems to actually undertake such monitoring and go to the GP practices when they are having other comorbidities. And it has also to do with the lack of motivation on the patient's part. So next slide, please. We looked at the standards for community mental health services set by the Royal College of Psychiatrists, by the College Center for Quality Improvement. These standards, they allow healthcare professionals across mental health settings to have a shared understanding of good quality care. The idea is also that the staff members, they arrange for the patients to access screening, monitoring, and treatment for physical health problem through primary care services, through the specialist care services, and that this should also be documented in the patient's care plan. The other standards, they include that the patients, they should be offered personalized, healthy lifestyle interventions, such as advice on healthy eating, physical activity, access to smoking cessation services, and this should be clearly documented in the patient's care plan as well. In addition, the other standards mention that the patients who are prescribed mood stabilizers or antipsychotics, they should be offered and encouraged to have the appropriate physical health assessments at the start of the treatment. So at baseline, 6 weeks, 3 monthly, and then annually, unless a physical health abnormality arises. Next slide, please. Next slide, please. Along with my colleagues Maxine and Marlene, we looked at what we can create in terms of monitoring of the patients, of the physical health of the patients by documenting various guidelines and looking at the standards. So we produce these physical health and well-being monitoring guidelines for forensic community mental health services. And the aim of these guidelines was to align the existing practices to the standards set by CCQI. What was the objective? The objective was to improve health promotion and to prevent diseases in our patients. The objective also included that we should have clear-cut baseline and then 6 monthly physical health reviews using our full-scale physical health parameters with outcomes, and that would include advice and referral to the relevant services while having liaison with the GPs. We discussed that the role of the SCPNs and the responsible medical officer is crucial in identifying the recovery areas and incorporating in care plans. So these could be looked at the CPA meetings, which are held 6 monthly for our patients. And once we complete these physical health packs, they would be looked at the point of CPA. So 6 monthly, that means twice in a year. Next slide, please. We produced physical health and well-being monitoring packs, and these were presented at our clinical leadership group within our service. And we agreed after that to set up clinics, but we also established audit tools, and we conducted a pilot study. I will just go over the contents of the pack. So each pack has certain subsections into it, which starts with the demographics, the contact details of the GP and consent form. It includes description of medications the patient is on, both for physical health and mental health. So any interactions, if there are any, could be looked at. In addition, high-dose antipsychotic monitoring section is there, which needs to be completed, along with the percentage of the antipsychotic. Physical health plan is again what the patient is able to describe in terms of any personal medical family history and any other movement disorders. Very important was the weight and BMI section, and to categorize whether the level of activities which patient have, whether it's mild, moderate, or high. There's physical health parameters, again, that includes temperature, blood pressure, SATs, and respiratory rate. In addition, other things that we would be looking at in this pack is smoking, drug substance misuse, which is drugs and alcohol. And essentially, it's lots of screening tools are used here to find out whether the patients are having problems which can be categorized as harmful or as a dependency. Then history is also taken on blood-borne viruses. For alcohol, the screening tools FAST is used, which is alcohol harm assessment tool, followed by the blood investigations. And we use the recommended monitoring for antipsychotics and mood stabilizers by NHS Lanarkshire. According to that, we do the blood investigations. In addition, we look at the serum assays of certain mood stabilizers. Another form that we have in this pack is GAS, which is Glasgow Antipsychotic Side Effects Scale. Looking at other aspects of the patient's health, physical health is if they have any problems damages from the eyesight or dental problems, sexual health problems, and how they can be referred on to these other clinics. In addition, bowel breast screening history is taken, whether patients have complied with the regional protocols for this or not, and sexual health history is taken as well. I will hand over to Marlene, who will take you through the physical health well-being monitoring pack at this point. Thank you. Angela, can you put up the pack, please?
I could maybe just introduce myself now at this point as well. So my name is Marlene Savage. I'm one of the forensic CPNs currently working with the forensic community mental health team here in Lanarkshire. Okay, so as Dr. Raja has outlined, she's spoke about the pack in itself. It is quite self-explanatory, but it is worth just running through it for a couple of minutes to explain in a slightly more detail some of the sections. So just moving along a wee bit, Angela, just to mention in particular, we chose this particular format and layout as we considered it to be the most patient-friendly. Again, as Dr. Raja has mentioned, historically our patients do have poor compliance with their physical health monitoring, and therefore essentially we wanted the patients to participate as actively as possible in their physical health and wellbeing monitoring. The first section there was just highlighting the consent. We did want to make it clear to the patient that the GP would be involved whilst it was conducted with our service, that the information would be shared with the GP. In most cases, it has been verbal consent, just because of the COVID restrictions during the pilot scheme. So yeah, moving on, we do have an information section here detailing all the patient's regular medications. Slightly further down, we have high dose monitoring protocol. So just to stipulate whether the patient is subject to high dose monitoring or not. Moving on takes us to the My Physical Health Plan. This section was quite helpful for our patients to have it written down, the history of their family's medical health. That often gave them an understanding of the potential links for their physical health issues, and also gave us an opportunity to discuss prevention of certain physical health issues. Moving on, we did speak about, we recorded the measurements in terms of their height, weight, BMI, and also their current activity levels. We included a BMI chart. We felt that this visual aid was helpful for the patients to have an at-a-glance view of how their BMI could change, whether it be improvement or otherwise. Again, giving us an opportunity for discussion about health improvement. The rating scale chosen was the Glasgow Antipsychotic Side Effect Rating Scale. This was most suitable for most of our patients, however, it was not applicable to some of our patients. The next section takes us on to, sorry, that's just the outcomes of the rating scale. And then we have a section detailing the pulse, blood pressure, temperature, as I say, self-explanatory, but again, worth having it written down for a visual aid for our patients too. We assessed their smoking status, the illicit drug use, and also their alcohol use. Again, this could be their current use, and again, an opportunity for health promotion and opportunity for referral to addiction services if necessary. So the blood investigations, as Dr. Raja had stated, we conducted blood tests in each of our patients. Then also an ECG was requested, again for most of our patients, but some of our patients this wasn't applicable. Urinalysis will regularly be undertaken, and also serum monitoring for, again, some of our patients on our caseload. Moving on, again, we spoke about this is more of a prompt to other general health topics, areas that our patients may not consider themselves requiring assessment in, but again, it gave us an opportunity to discuss these in terms of health promotion. For the final part of our pack, we included the summary of our findings based on the particular assessment at that moment in time, discussed the goal and the action plan in terms of what our patient would look forward to for the future and how we can support them in achieving this. The outcome of the assessment was then relayed to the GP via a letter, and this is a template of that letter with some of the requirements we would like to include to the GP for information. Thank you for listening. I'll take you back on to Dr. Raja.
Thank you very much. Can we go back to the slides where we left? Next slide, please. As Marlene had very clearly mentioned, the last stage is about referrals and outcomes for our patients. So it's also about signposting the patients to access local services. In terms of one section on the level of activities, how we go about is we use the clinical guidelines to categorize the level of activities for the patient. And these are nice guidelines. Advice is given to the patient on how much activity they should be taking per week in terms of duration and the style of activity in terms of physical exercise that would help them. Other advice is lifestyle choices that they can make, and we would be providing them with leaflets on healthy diet and nutrition as well. We agreed that patients who attend Cared House for drop-in sessions, a service which is run by the nursing staff at Forensic Community Mental Health Service, which is weekly, that at the same time we will be conducting the physical health and well-being clinics once a month during or over a year period, and that there is a flexibility in that. Quite a number of patients, they can be attended to, or we can investigate various blood investigations can be undertaken on site as well as in their homes if the patients are not finding it easy to travel to the cared house. However, a pack would be completed with the patients and bloods would be undertaken for investigations. As Marlene had explained, that following the receipt of results, blood results, GP will be informed accordingly about any abnormal bloods, and that this would be undertaken 6 monthly. Following the approval of these guidelines, a pilot study was undertaken over a 3 months period starting from January till March 2021, and we had also created an audit tool. I will now hand over to Maxine, who would be presenting the outcomes of the audit tool.
Hello, my name is Maxine McDougall, and I'm another of the forensic CPNs who took part in this process. We held our pilot study between January and March of this year, and there was 12 patients took part in this. So that was 2 for every CPN. Next slide. It is quite self-explanatory, but I'll just go through it briefly. We came up with a pie chart on our findings. So our consent to share information, it looks it's 50% consent and the other 50 looks as though it's not recorded, but this was simply because it was taken on a verbal aspect. Again, this was due to COVID. Next, please. The part that Marlene already showed you, the copy is enclosed in all our ICP files, and this is made up prominently. We chose to make it the colour green, and this is to make it easy access to anyone who's looking for any information required. Our ECG baseline is something that we have noticed. We have 42% and 58% people did, but we are going to improve on that as the CPNs have now been trained in taking ECG, so this should make it easier for us and our patients. Next, please. Prescribed medication and allergies, as you can see, was recorded at 100%. Next. High dose monitoring is showing up 50%, but that is because not everyone requires to be in a high dose monitoring status. Next. My physical plan, as Marlene explained herself, was 100%, which gives the aspect of historical and how the patient sees their physical health at this current time. Next, please. Body mass index was recorded for everyone. Obviously, this is important when we're looking at their weight, etc., for any heart defects. Serum monitoring, again, shows a 67%, but not everyone is on any of these drugs. Next. 100% for our substance misuse. Again, as Marlene, Dr. Raja has mentioned, this is so we can, it's easy for intervention and quick intervention should there be any problems identified. The Glasgow antipsychotic side effects rating scale was used, and 83% of that was fully complied with. Again, the rest are possibly not on antipsychotics that require them, or there was maybe difficulty due to COVID or that getting results. The summary and findings is self-explanatory. That was 50% each, and again, these are things that will improve through time. A relevant blood test, where in the last audit they were specific blood tests asked for, we have done it collectively, and that is basically we have checked all the routine bloods that are important to everybody. Next. 73% have responded to the GP by letters, but that is a thing that we have to improve as well, what we will do in the future. Everyone's physical health, their high dose monitoring is already discussed at our CPAs. This will just become a bit more in depth now. Electronically stored is actually being reviewed at the present time, and that will do it. Right, thank you. Back to Dr. Raja.
Yes, hi. Thank you very much, Maxine, and thank you, Marlene. So comparing the outcomes from the pilot study in a bar chart, as it is clearer actually from this slide, definitely there has been improvement in certain physical health parameters as compared to how things were a year ago. I think it is self-explanatory, and this has been explained well by Maxine and Marlene. So the reasons for the section in the bar chart where it's orange highlighted means that some of the things were not done, but quite few of these patients did not require the serum monitoring or the high dose antipsychotic monitoring. Next slide, please. We did notice a huge improvement in how the gas forms were completed. The histories were taken in regards to the substance misuse. The physical health side of things were better recorded as well. However, we still noted that there were a few things which we needed to improve upon. Next slide, please. The recommendations from the pilot study highlighted that we still needed to make sure that we were liaising with the GPs and we were providing them with letters which would highlight any abnormalities in the blood investigations, or if we are asking them for a referral to the services, that this should be done within a certain time frame. We also recognized that although the service had electronic sharing of these folders, that the information needed to be shared electronically with the GPs as well, not just through the letters. We noted that we needed to improve on the ECGs, especially at baseline, as well as improving upon high dose forms, plus ensuring that the serum levels for patients who are on mood stabilizers are completed. Despite having said this, the outcomes of the pilot study was a success, given that there was a huge improvement in the recording of the physical health parameters, as evidenced by the statistics which has just been shown in this presentation. As a result of this, the physical health and well-being clinics, they have now been set up and they are part of our forensic community mental health service. As mentioned previously, these are now jointly done between the CPNs and the RMOs. Myself, I provide half a session per month, and there's a flexibility in that, and we complete the monitoring packs with the patient, which is a patient user-friendly monitoring, physical health well-being monitoring pack. Over the next year, what we propose is that the audit tools will be used throughout the year at 6 monthly interval, and at the end of the year, the results will be presented again at the CLG within the forensic mental health service, and we will compare at that time the results with our current results. All in all, this project was a quality improvement project, and it did improve the physical health monitoring of the patient, and we are hoping that with time that there will be better monitoring and treatment of physical health conditions of the patients as a result. This project could not have been completed without my colleagues who did most of the work, Maxine McDougall and Marlene Savage. So I'm grateful to them for their input. I'm also grateful to Angela Ray, who is our admin and helping out at this point in time with our presentations. If you have any questions, please email on my email, which is aisha.raja@lanarkshire.scott.nhs.uk, or you can contact the Forensic Community Mental Health team at Caird House, and you can leave the message and we will come back to you. Thank you very much. And Maxine and Marlene, if you want to say final words at this point.
Okay, thank you, Dr. I would just add that, again, as I've already said, the way that we have set up this project really helps to combat the previous barriers to achieving the physical health and wellbeing monitoring for our patients, and just that we have all, quite happy to take a flexible approach in how we obtain all this information, working with the patients to best support them, whether it be in their house or at clinic. has been definitely something, you know, good to be part of, and we're looking forward to continuing this in the future. And again, as Dr. Raj has mentioned, please don't hesitate to contact us via email if there's anything you want to ask or discuss, or for comments would be great. Thank you. Maxine is also going to just say a quick bye.
Thanks very much. Just as Dr. Raja and Marlene have said, any comments or any questions, don't feel to get in touch with us. Thank you. Bye.
Thank you very much, and we can conclude the presentation.